We've talked about interoperability. We're now talking about a unified approach to Scan4Safety in the UK and Ireland. Okay, I gave you a historical perspective for the previous panel, 2013. As it happens, my historical perspective for this one is also 2013. In 2013, maybe 2012, I think, we had two potential catastrophes in healthcare in the UK. We had the breast implant scandal and the metal-on-metal hip scandal. So two sets of implantable prostheses where things went wrong. Many of them inserted in the private sector. That wasn't a problem. The NHS very quickly stepped up to say, irrespective of which provider put the implant in, if you have a problem, come to us, we will remove it. The actual problem was tracing who had which implant, because it was only the PIP implants made using industrial silicon by a firm in France that were responsible for the breast implant scandal, and it was only metal-on-metal hip implants, not other ceramic or other types of implants. I was asked by the Medicines Healthcare Regulatory Agency to conduct an independent review of that, and that's really the first time that I clocked the potential role of scanning, barcode scanning, 2D matrix scanning, the idea of a very high-fidelity system using an infrared scanner to take all the data about implants and keep it in a record. And we made recommendations, all of which, the group I convened made recommendations, all of which were accepted, around the idea that the NHS needed to embrace a universal device identifier, a unique device identifier, and would record person, product, place, and ideally the person who'd put the device in. So we are 12 years on from that. I think things have moved forward hugely again, not least thanks to the Scan4Safety pilots that showed unequivocally the benefits as were imagined, as work imagined in 2013 became reality. So I'm delighted we've got four experts here from all four nations to talk about a unified approach to Scan4Safety. And I'm going to start with Kelsey Flott, who's Deputy Director of Patient Safety at NHS England, to kick us off. Kelsey.
Thank you very much, and thank you for having us. Hi, I'm Kelsey Flott. I'm Deputy Director for Patient Safety, specifically for digital in the NHS England National Patient Safety Team. So that leaves me with the position of talking about a unified approach for Scan4Safety from an England perspective while NHS England is being abolished. So bear with me while we try to think through actually how some of the principles of Scan4Safety will endure regardless of the kind of organizational change that we're looking at. And hopefully we can use the theme that's coming out today, which is that we are in a time of change, and hopefully that opens up a window of opportunity for doing some of the things we want to do in terms of a unified approach and unifying some of the standards around Scan4Safety, the processes, the kind of next steps. So that's the perspective from today. Quick step back. We heard in the plenary this morning that we don't hear much about safety anymore. I think that is true compared to the days of Jeremy Hunt and standing up a lot of safety programs and publishing the National Patient Safety Strategy. But part of the context to Scan4Safety is the National Patient Safety Programme in NHS England. And since the publication of that strategy, we have launched the new Learning from Patient Safety event service, the new Patient Safety Incident Response Framework, put patient safety partners in organizations, as our Patient Safety Commissioner mentioned this morning, implemented patient safety specialists across the NHS, a number of other things, including the first NHS digital clinical safety strategy. And that strategy really set out the kind of two aims nationally for improving the safety of digital technologies and also a national approach to using digital technologies to drive safety. So the biggest part of that second component, that how do we use this technology to drive safety, one of our biggest pieces of work has been around Scan4Safety. So Scan4Safety in England, since the pilots in 2016, has not been a kind of national funded program where you see NHS England funding new pilot sites. Instead, it's actually been kind of a coordinated effort between a number of moving parts. And I think when we look at the change at the center of the NHS. We have to remember that Scan4Safety depends on the centre working really closely together. So Scan4Safety, as a sort of principles of using barcode scanning to capture person, place, product, and process, means that we need to have NHS England patient safety team working alongside this to capture the patient safety benefit. We need to have the regulation right from MHRA. We need to be working really closely with our supply chain colleagues who spoke earlier about the inventory management system and point of care scanning in theatres. We need to be working really closely with the department on the PIM work, which came up in the last presentation. And getting all of those pieces right is the foundation we need to move Scan4Safety forward at a national level. So that's why we kind of do that coordination piece in NHS England. I think Scan4Safety, despite not having a huge kind of pot of funding in NHS England, is expanding. We're seeing lots of different use cases for Scan4Safety beyond kind of theatres. We're hoping to get, I know we'll hear more about this tomorrow, but medicines, medication safety, blood products. I'll expand more on some of how the program is going, but I think hopefully what we can do in terms of creating a unified approach is not just getting the standards right and the basics right, but using this as a case to do that piece, which is changing the narrative on safety. Safety has to be an enabler to digital. It can't be the thing that holds digital back. So if we go back to how we used to talk about safety, which is if we get safety right, if we take it on board and own it, it can be an enabler to driving these things forward and making them work in trusts.
Thanks, Kelsey. I'm going to turn next to Andy Mallion, who's the National Clinical Lead for Scan4Safety for the Scottish Government and a plastic surgeon. Andy.
Thank you. Yes, I'm another bloody surgeon. There are more of us about than you think. So in Scotland, we have a slightly different situation to England. I think we've probably got slightly more of a central direction, which is a great thing to have. The Scottish Government procured centrally an inventory management system which was rolled out to all of our 15 health boards. And this also has a point of care scanning module, which gives us the capacity to roll out a Scan4Safety program with a very central drive to it. That should make it really easy, shouldn't it? But the problem is that although we have common standards, which we can describe because we have a central team who go into the boards to push that implementation, each of the health boards up to this point has been allowed to develop its own IT environment. And of course, they all have ice cream, but it's in 15 different flavors. And if you ever try mixing pistachio, chocolate, raspberry, and mint in the same bowl, it does get quite unpleasant. So we still have challenges, despite the fact we have the advantage of that sort of central drive. We're making progress. We're live in 4 boards. We've got about 5,000 hips and knees where we have identifiable data for those patients. And we have about 13,000 patients who've had cataract surgery now where we've got traceability of their implanted lenses. What really matters, though, from my point of view, on the patient safety front, is that we get what comes out the other end. We get this wonderful database, this great data set with all the information about the patients, their procedures, and their devices. We have, in Scotland, some registries. We have Scottish Arthroplasty Project, Scottish Cardiac Audit, which look at what they look at. And actually, to some extent, the Outcome Registries Program, the Federated Data Platform, is doing the same thing. It's looking at what it looks at, but it isn't looking at everything. Who looks at lenses? And lenses are actually probably the commonest, well, not probably, lenses are the commonest device that are implanted across the UK. but nobody actually looks at safety. And there was a patient safety alert at the beginning of last year, and certainly I know that in Scotland we had 8 patients who lost their sight because of those devices. So we've got to make sure that if we have this data, we look at it. There is a moral and an ethical obligation on us, not just to have it, but to share it, to look at it, to understand it, and then do something about it. And I think I've seen Patrick here from the Outcome Registries Programme. National Joint Registry is fantastic, because if you look at the last 2 patient safety alerts that came out of National Joint Registry, they both open with the phrase, based on data from the National Joint Registry. Now, when we can all feed that data into these registries, that's when we are actually starting to really achieve something for patient safety. Scotland's got a tiny data set. We're 10% of the UK. We need to be a part of the overall collection. We need to make it 110%, being with England and being with Ireland and Wales, so that we can actually get useful, good quality, best quality that we can, patient safety data.
Thanks, Andy. We're going to go to Wales next. It's not Rupert Chilvers, as in your programme, it's Tracy Francis, who's the reference data and terminology lead for Digital Healthcare Wales. Tracy, thanks for coming.
Thank you. So yes, I work for Digital Healthcare Wales, and I've been working with the Scan4Safety programme now for about 3 years on developing the standards. In Wales, we've got a long-standing assurance process that's been in place for over 20 years. Welsh Government supports it, and it backs mandates. So that's how we function within NHS Wales. So like I say, I've worked with shared services who are part of the implementation programme for the Scan4Safety teams. And like I say, I've been developing the positive patient identification standard. We have engagement with all of our clinicians where we can. So we do some big stakeholder engagement, hold workshops. We've had to follow-up workshops, because like you say, when you're trying to introduce a standard, you need to have that flexibility, you need to understand the requirements, otherwise if you can't implement it, it's no use. We have additional requirements, so we have followed very closely the NHS England standards that have been published. But there are some differences that we've identified within Wales, so we're taking those on board now. As part of our assurance process, then we'll be able to publish our standards, and that'll be backed up then by a Welsh Health Circular. So, you know, that's my side on that standards development process, let alone all of the clinical engagement that we need. But just to highlight one incident we had, which I'm sure you all would have been impacted, was the vaginal mesh. We couldn't identify those in Wales. We had to use secondary care coded data. We had to change our coding standards to be able to identify it, because we haven't got those standards there in place. So that's why, obviously, our main aim is to improve patient safety, have those standards, and like I say, we're hoping to be rolling those out in the next couple of months, those standards. And like I say, working with all of the trusts and health boards. We're small, so that's good for us, but it is hard.
Thanks very much, Tracy. And finally, we're going to Ireland. We're fortunate to have Richard Green here, who's Chief Clinical Information Officer at Health and Safety Executive, the kind of equivalent of the NHS in Ireland, and an obstetrician and gynaecologist in Cork. Richard.
Thank you very much. Thanks for the invitation to speak on the panel. So we're in a slightly different place. So any of you that go watch the OECD, we're considered the lowest in the OECD with respect to digitization of health records, despite the fact that Ireland, privately and commercially, is considered one of the leading digital nations. So we're way behind in health. As a Chief Clinical Information Officer, I'm working with my Chief Clinical Officer colleague. One of our biggest problems with all of that is we actually live with unquantifiable risk right across the health system. We don't know what's going on. We have massive problems with duplication. We have some systems, but they're very varied, very siloed, and the majority of our records, once you walk out of the acute hospitals, is effectively paper. So it's a very different kind of picture. We do have a national policy called Sláintecare, which basically is the Irish language for healthcare, and it is all about integrated care. But we can't achieve integrated care because we're not moving information around to do that. We also have a significant requirements coming down the track from Europe, particularly the European Health Data Space, which is also putting requirements on us. And probably the greatest of all is our patient expectations, that, you know, I can do everything with my hairdresser or whoever with my app, why can't I do it with my healthcare? And that's a very common kind of comment. So last year we actually launched the digital health. The Department of Health launched Digital for Care, a digital health framework for 24 to 2030 to try and reverse all of that. And we have a significant number of projects in train already, and very much following that framework, of which the patient is absolutely central. And principle number one is the engaged and empowered patient. And we have a lot of patient activity and involvement in all of this. So we just launched a patient app, equivalent to your NHS patient app. In February, we're about to go live with the shared care record, pulling generally administrative data from the health services, plus our GPs are pretty well digitized, so we're going to be hopefully pulling clinical and medical information from the GPs. We have quite an active kind of telehealth and virtual care developments, and we're about to go out to procurement later this year for a single EHR across the country. Now, when you say it's across the country or national, you know, that sounds big, but actually we're just a little bit bigger than many of your trusts, you know, so we always equate ourselves to Greater Manchester. The population's a little bit bigger, but in terms of doctors and nurses and staff and all the rest of it's not that similar. One of the things that we are doing, though, is we've had a long relationship with GS1, but we're actually formally adopting GS1 standards across the whole Digital for Care programme. And mainly because of the standardization around identification, standardized barcodes. Siobhan mentioned that already when she asked a question, and also that the software that we're looking at is GS1 compliant. So we're actually building that into the whole program. The key drivers, to be honest, is patient safety. And for any of us clinicians who are involved in this, it very much is around patient safety. And we have a lot of the things that were already mentioned about the patient safety requirements and all the rest of it, and we've been doing that. We have had some pilots with Scan4Safety, and they have shown very similarly to the ones here, the benefits, and that's helping us to move that forward. And I suppose in the end of the day, one of the reasons that we're plumbing for this is that in a way we're using it in reverse of the canary in the coal mine. We're using it as a kind of an entry point to actually show people the value of standardizing data right across, which will allow us the patients to move around, to be accurately available, their information to be accurately identifiable, and that the clinicians can actually do their job in a safe way. So that's kind of where we're at with this and fitting in. So inevitably, we're learning from the stories here and very much keen to be involved so we can learn more and do a good job on it.
Thank you, Richard. Can I start with you, Richard? You were mentioning you're on a journey with an electronic patient record system. I think Tim Ho hinted at this in the previous panel. You said yours is scan compliant. I remember when I was at University College Hospital, we introduced Epic, but we couldn't scan. Again, it was an interoperability. We couldn't scan information straight into Epic, which seemed a great failing. I don't know if any of you have got comments about making sure that electronic patient record systems can scan information from people's medicines or their wristbands, or whatever, straight into Epic rather than having to be entered by hand. Richard, you're doing that in Ireland?
Well, so we're in the process of going out to the market, but actually we're actually going to make these requirements, to be honest. And I know we'll have a battle with some of the providers that are out there. But I think that we're actually very fortunate. We're so far behind. We're actually very fortunate that we can learn from a lot of the lessons that other people have had difficulties with. And so will we achieve it? I don't know. But in a way, to go back to Min's comment in the last one, is we have to actually begin to set the requirements, and people have to start to begin to come to meet us. And that's kind of where we're kind of setting out with.
Okay.
My name is Ben Newman. I'm a clinical engineer from Guy's St Thomas's. My question's for Andy. It's around the implementation that you did centrally just going back and looking, now you've got different flavour, your ice cream analogy. If you were to do it again, are there lessons learned from that? Was it a necessity to end up with the different variations across the different health boards? How was the approach? How might you approach it again, if not?
Okay, so sorry, to be clear, the 15 different flavours of ice cream comes from the historical elements. So this is from prior procurements by boards when they've been buying their EPRs, the packs, all the other systems. What happened at the beginning of our Scan4Safety programme is that the Scottish Government bought a single inventory management system, which was rolled out centrally. So everything has been done centrally. And we are trying to keep as firm a grip as we can on each board as we go in to do the first rollout to make sure that it stays the same flavour so that it's the same everywhere. And that's a challenge because all of our boards regard themselves as fully autonomous organisations with their own chief execs, IG setups and everything else. And despite the fact that we try to do a lot of the legwork for them beforehand, they will still try and second guess it or still try and put their own particular stamp on it. But we need to have this level playing field, don't we? We need to have and I think the point you were making earlier about defining what we want as organizations, a minimum standard data set, I think is just such a basic concept. But the problem is there's so many organizations. We're lucky in Scotland. We've only got 15. I feel really sorry for you in England. That's why I moved north.
A question primarily, I think, for Kelsey Flott, if that's okay, is I think we've heard that the Product Information Master is something which NHS England is going to be developing, but of course all the different nations will need some sort of Product Information Master, and I imagine in Scotland you already have something for your inventory management system. So I'm wondering, is there any kind of way that could be used to integrate or help the different nations get to a level playing field?
So thanks, Phil, and I think absolutely. So the Product Information Master is currently being developed by the Department of Health and Social Care, so led by David Lusson's team, and I believe, because of its position in the department, that it is already kind of a four nations piece of work. Colleagues can correct me if I'm wrong about that, but yes. So I guess the principles of that would be that everything that goes into that database will be uniform, and all four nations would be able to use the data within it and kind of benefit from the standardization of that piece of work. It's also moved along quite a ways. I think that they're now in a second phase of developing the beta phase of the PIM, and there will be unique identifier codes in that PIM, so that should be quite helpful to unification.
Yeah, so my name is Ish. I'm Associate Director of Information System at North East Hospital. If we're starting Scan4Safety deployment from a fresh start, what are your views? Because in my head, we go one of two routes. We either go down the route of an inventory management system solution primarily with a patient safety as a byproduct, or a patient safety centered solution on Scan4Safety with an IMS linked to it. And there are pros and cons of both. And the products that we've got out there do one or the other. Just wonder what your thoughts are on the pros and cons of each of these methods.
Do you want to start, Kelsey?
I can start. So thank you. And I think you've highlighted part of the concern we have with Scan4Safety is that it has been driven from this kind of IMS and procurement route, which sometimes could leave out the safety piece. It becomes that scan to save rather than Scan4Safety. I think what has changed, though, in working with NHS supply chain is the IMS program now for developing an IMS system, I think embeds those safety principles within it. So you have point of care kind of connected to IMS rather than doing one or the other. And it would be hard to do end-to-end scan for safety without your IMS right. So I think that kind of is a fundamental point of it. But you would need, my view on it, is that doing that requires the clinical engagement and the sort of senior leadership engagement rather than just a procurement and estates and infrastructure piece. So I would say it's about doing the IMS piece in collaboration with your clinicians and safety lead.
Tracy, do you want to add a Welsh perspective?
Yeah, no, I would agree with that, because you can go either way, but you need to understand that all of it, be able to pull it together. So, yeah, you can easily run away with get the IMS in and get it set, but you need to have that clinical safety aspect up front. It's not going to work. It's the easy thing, not the easy thing, but to drive, isn't it? To say, oh, well, we can get that in and we can get it set up, but you've got to bring it all together. And that's where we're slowly now coming out with that now, to say, I know, I'm bringing all those pieces together to drive then that safety and get those benefits.
I'm Tony Naylor, Scan4Safety lead for North Tees and Hartlepool NHS Foundation Trust. Leading with IMS may be more historical, more typical, but it is not the only way. We started with Scan4Safety, and we're very proud of what we've achieved. And Medical Device Outcomes Register, for example, we've already submitted 38,000 rows of data going back to July 2020, based on our collection of data easily at the point of care during theatres. We have full engagement with our staff, as Isha's mentioned. They run the system, they own it, they design it. And for us, it's a breeze now to follow into IMS, because we know there are financial savings and gains, having better stock control, ordering what you've used when it's the right stuff to order, having good own and consigned stock management, all of the pieces. But we also load all of the MHRA alerts, whether we use the products or not, against a database of 80,000 records now. And incidentally, that data is available to be shared. And that's what should happen with the PIM. The PIM, and I'm eagerly awaiting it, we've spoken about it for 8 years now, the PIM should be free at the point of use via an API. There should not be a subscription need, and everything should be a high quality, and together we should ensure that high quality by providing the data from the sources that we have that are real, and obliging our suppliers to meet those requirements or otherwise not gain our business. So you can do Scan4Safety in different ways. We started with safety, we moved to IMS, but together we all gain from what we do in implementing the GS1 standards.
Thank you.
Agree?
Anybody anybody want to add anything to that?
No.
I think what matters with patient safety is that we have the right data set at the end of it, isn't it? We need the traceability, and we need to be looking at our outcomes. And those are the two things that will really build into the patient safety element. And how you get them, yeah, I agree. There are many ways that you can skin the poor old pussycat, but so long as we get what we need out of it, it doesn't really matter.
Hi, Patrick Parr from NEC. We run the National Joint Registry, amongst others, and the Outcome Registries programme. Just to say, the IMS or even the PIM isn't the complete answer from a patient safety point of view, because often it's the particular characteristics of a device, the classification of a device, that determines whether or not a device is successful or not. We know that through the concerns around cobalt with joint replacement and with the BCIR, where we need to classify implants as having smooth or textured surfaces, because that can often influence it, and that isn't necessarily available through the barcode. So that's an important aspect of it that we also need to consider.
Okay. Any comments?
Only to say, completely agree, and actually some of the getting the foundation right, I think, will enable us to get those other pieces, but yes, absolutely, there are lots of parts to make this right.
So maybe that reflects the point about we need the data. The data has to be what's required to ensure patient safety. Yes, one last question here.
Hi, Phil Lapish again. The other thing, to back up the data, we need it to be easy to actually capture at point of use. And I always mention this, and it's probably going to do it later. Barcoding is only good if we become more prescriptive to our manufacturers and suppliers about not just what to do, what not to do. I will be talking later in my breakout session, but I've got examples of products that have got 5 different barcodes on them. When you're trying to train hundreds of clinical staff every year, newcomers to the organisation, what they're supposed to capture, what they're supposed to scan, we need to follow retail. We need to have a singular barcode on our products at point of care to make it easier to capture this information. Because if you don't know what you're supposed to scan, then chances are you're just not going to do it.
A wise reminder that you can have too much data as well as too little. Okay, I'm going to again take Chair's prerogative to ask final. I'm going to leave Kelsey deliberately last because the other 3 countries have, I think, more of a centralized system, if you will. But I'd just like to ask each of you that tension that you may be alluding to between a national direction or national prescriptive, but allowing people locally to be entrepreneurial, to have a local initiatives. I'll start with you, Andy, in Scotland, because you kind of hinted at it already.
So I think the core system needs to be respected and left to stand as it is. What individual boards do with the data that comes out of it, that is much more down to them. So I'm quite happy to see a lot of initiative because it'll all result in eventually shared learning and the best of it will come out and hopefully be adopted on a wider basis. Okay. So leave the core system alone and encourage innovation.
Tracy.
So like I say, we generally have quite a few engagement sessions because we're quite close with our local health boards and trusts. So we would try and gather all those requirements and understand what's our core data set that we need. And if there's additional things that they would like to capture, they could, but it's not necessarily mandatory. So we would try and, include it in so it's a clear data set, but identify what is our core minimum requirement that we'd need, and then allow the flexibility.
Thanks. Richard.
Yeah, again, we're going for a kind of a national consistency with the regions actually involved in that design and development. It's their job to implement it, and if they do something beyond that base, that's fine. I think, to be honest, if we all got that core, they'd be all very happy as well.
Yeah. And Kelsey, you got the difficult position. So NHS England has been abolished, still with us. So not abolished yet, it will be abolished. You hinted at this in your opening remarks. Can you say a bit more? Will there be a national Scan4Safety system? Will the centre under Jim Mackey be more directive from prescriptive, or will it allow 1,000 flowers to bloom?
Thanks. And I think while I would never speculate on what's going to happen within NHS England in the next 5 years, let alone further, I think that what will remain is the kind of principle and the need for this. So it is very clear with the 3 shifts that we need to move from analog to digital. With that, it comes the work that Ming was talking about some of the standardization and making standard requirements. And I think we have an opportunity with a kind of more centralized centre where we actually can be clear on what our standards are for the market, which should then kind of filter down to what are quite a vast number of trusts and providers to work within those standards. So hopefully we can use that opportunity. But I do think the need for this will be consistent regardless of what organizations exist tomorrow.
Lovely. Please, can you put your hands together for our panelists? Thank you all very much.